is I wanted to okay. You see that okay? Yeah,
Yes, thank you.
great. So I wanted to share with you some work I'm doing around patterns of um, psychedelic drug use among people accessing inpatient mental health services in Ontario, Canada, and explore some of the patterns and relationships between psychedelic drug use and other substance use, as well as some of the demographic and clinical characteristics that are associated with those who have used psychedelic drugs. Um, just in terms of disclosures, I do want to mention I am a fellow of a not-for-profit group called Intri that designs assessment systems that are used in healthcare. For instance, Intri's developed tools that are mandated for use in nursing homes across the US and Canada and home care agencies as well. And they've developed mental health instruments as well that are used in Ontario and form the basis of the presentation I'm going to give today. So, in relation to that disclosure, I don't receive any income or honoraria from Intri. I do receive a small research fund that I can use towards ongoing research activities from Intri. In terms of psychedelic drug use in the population, um, we know that there are a lot of changes happening very rapidly in terms of our understanding of potential roles that certain psychedelics may carry in therapeutic processes. We know that there are some potential clinical benefits of psychedelic assisted therapies for certain mental health conditions. There's even been some work done looking at and reviewing evidence around the utility of psychedelic drugs as an adjunct to psychotherapy for people experiencing substance use disorders. There's some um, limited evidence for psilocybin, sorry, that's spelled wrong, and ketamine, for instance. But there's a lot of work still to do in that area, but it is changing very rapidly. If we flip to naturalistic use, we from survey data, we also know that there are a lot of people report, improvement in their symptoms and mental well-being after engaging in naturalistic use. Now, again, those are self-reported results. They don't necessarily mean clinical improvement, as many of you would know, of course. What's interesting is if you do look at population-based surveys of past year psychedelic drug use, there is a strong association between those living with mental illnesses and engagement in psychedelic drug use, as well as poly substance use and polypsychedelic drug use as well. So, using psilocybin, LSD, or other psychedelics in combination. When we start to look at survey and population-based data, we know that there is also a rapid increase that's occurring in the percentage of people reporting that they've tried or used psychedelic drugs in the prior year. For instance, in 2023, survey data from Health Canada, so this is nationally representative survey data, reported that 12% of youth reported past year hallucinogen use. Um, and that is at a population level was associated also with an increase from 2% reporting among the entire population, not only youth, in 2019 to 6% in 2023. These changes mimic changes that we see from survey data from the United States as well, where, for instance, LSD use has increased among 18 to 30-year-olds between 2018 and 2021, a relatively short period of time, from 3.4% to 4.2. Other hallucinogen use increased from 3.4 to 6.6%. Um, Presumably, that's being driven more by probably psilocybin. When we look at people who've experienced, concerns or problems related to psychedelic drug use, we often look obviously to emergency department data. And there was a recent study just published from Ontario data, that looked at all emergency department visits in the entire province from 2013 to 2021, um, uh, somewhere over 10 million visits. And what they found there was ED visits for hallucinogen related issues rose by 86%. Now, overall, as a percentage of total ED visits, it's still relatively rare. However, it's a fairly substantial increase in the number of visits that are occurring. What's interesting from these data is what they did was, uh, and my apologies, I forgot to put the citation there, but I can send it out. Um, they linked the ED data to physician billing data over a 3-year period following the index ED visit, and found that those who were visiting the ED for hallucinogen-related issues were 3 times more likely to be diagnosed with schizophrenia spectrum disorder over the next 3 years, compared to those with visits for other reasons. The change in ED visits is not only in Ontario, of course. There's a study also out of California that showed from 2016 to 2022 there was a 55% increase in ED visits related to hallucinogen use, compared to only a 1% increase for alcohol or cannabis related concerns. So psychedelics, of course, are very front of mind in clinical discourse, but also in public discourse. And there seems to be a changing environment around naturalistic use that is affecting emerge department visits. What we don't know, and we haven't looked at as much, is to say, well, what are the trends associated with psychiatric hospital visits at a population level? And so that's what the study I'm working on uh, attempted to sort of look at was to say, well, what's the prevalence of psychedelic drug use among those admitted to inpatient psychiatry in Ontario? What's the prevalence of polysubstance use in association with psychedelic drug use? And what are some of the trends that we are seeing in the number of people being admitted to inpatient psychiatry who have used psychedelic drugs prior to their admission? So we did a cross-sectional sort of trend analysis of people at first admission to inpatient psychiatry. So in Ontario, there's about 72 hospitals that have inpatient psychiatric beds. About 11 of them are standalone psychiatric hospitals, so they have acute services as well as various specialized services, including concurrent disorders, programs for trauma, and so forth. But the majority of beds, about 80% in Ontario, are acute psychiatry beds. So what we did was we selected the very first admission for each person to inpatient psychiatry. The other catch here is the data I'm showing represent people who have been admitted for at least 72 hours. So they're not short stay visits, they're not acute visits. These are people that have experienced a more full admission. That was done because the data that we have are not complete for those with stays of less than 72 hours, and I'll explain that in a moment. Um, so we also excluded people in forensic psychiatry beds because of the administrative nature of forensic services. It was very hard to determine um, um, a person's ability to be even exposed to the opportunity to use a psychedelic drug prior to their admission because they may have been involved in the court system and so on. We also excluded those under the age of 18 as the services that we're looking at were designated to be adult services. Now, that said, there are sort of individuals in who are admitted to these beds sometimes who are under the age of 18. If there's basically a bed available and there's too many people waiting for the child and youth beds, it does occur sometimes, but we restricted it to 18 and older. We excluded those over the age of 65, simply because substance use and psychedelic use was so rare that we decided to exclude those folks. For the most part, in these data, those folks would be people with experiencing complex issues related to dementia who end up getting admitted to these beds. So the variables we were looking at were substance use based on the time the person last used. So that's actually rated from us, any use of cannabis, hallucinogens, opiates, cocaine or crack, stimulants, or inhalants within the last 3 days prior to admission, all the way to the last year prior to admission. And we also had a sort of a suite of demographic and clinical symptoms as well as DSM-5 diagnoses. So just to provide a bit more detail about the data, in Ontario, every person admitted to inpatient psychiatry is assessed with the Intra Mental Health assessment. They're assessed at admission and discharge. If they're a long stay patient, then they would be assessed at 90-day intervals leading up to discharge as well. It's a comprehensive standardized assessment tool. It's been mandated since 2005 for every person admitted. The designated clinician overseeing the care of the person is designated to take responsibility for the assessment. But the assessment's meant to use sort of multiple perspectives. So some hospitals, for instance, have different disciplines, complete different sections of the tool, social work, psychology, psychiatry, nursing, and occupational therapy as well. Other hospitals have nurses complete the assessment. When they complete the assessment, it's meant to be based on observation of the person. It's not simply a self-report or an interview with the person. It can be involve chart abstracting and review as well as discussions with first responders or people involved in the care of the person as well, to triangulate what the most responsible answer would be. So, for instance, one of the items on the instrument would be hopelessness. That item is scored from how often has the person expressed hopelessness in the last 3 days. Every day, two, 1 to 2 times, but not every day. Known to be present, but didn't observe it in the last 3 days, or not present. So again, that the answer to that can be ascertained from multiple sources, similarly related to substance use. So substance use is not only the self-report of the person, in terms of the clinician asking when was the last time you used a psychedelic drug like psilocybin or acid or LSD, things like that. They can also talk to family if the person's designated family to be involved. They can talk to first responders to say, yeah, when I picked this person up, this is what was happening. So again, they can have multiple sources of information. The domains on the tool include demographics, mental status, so a variety of depressive symptoms, symptoms of mania, symptoms of psychosis, cognition and daily functioning. So there's a cognitive scale, for instance, that's been validated against the MMSE and the MoCA. Physical health is included, including the person's rating of pain, patterns of substance use, social functioning in terms of having a confidant, conflict with others, the nature of social relationships, as well as patterns of health service use. For instance, if they've been engaged with community mental health services prior to their admission. So again, there are embedded scales. So for this study, we look specifically at the positive symptom scale, which measures the presence of hallucinations, command hallucinations, delusions, or abnormal thoughts in the prior 3 days. And it creates a scale that sums from 0 to 12, meaning higher score, meaning more symptoms are present. So all of these data from the hospitals are aggregated by the Canadian Institute for Health Information, which is a non-government organization that receives funding from Health Canada, and they're a national repository for health system data. And so they hospitals report the data to the CIHI or CIHI every quarter, and CIHI then runs data quality checks and so forth, and produces reports back to the hospitals on the data. We have a data sharing agreement with CIHI at the University of Waterloo, and that's how I was able to access these data. So I, I'm surprised I didn't have the sample size here, but the total sample was over 30,000 people that we looked at. Excuse me, much more than that. Sorry. I'll look that up after. My apologies. I thought I had the total sample size here, but you can kind of do the math because psychedelic drug use was prevalent in 3.5% of the total sample, which was 3,262 people in our sample. So relatively rare in the total sample. These results show us the variations in when a person had last used a psychedelic drug prior to their admission to hospital. So, 1.3% reported having used in the 91 to 1 year prior to hospital, about zero point 0.5 used in the 30 days to 90 days, zero point 0.7 used 8 to 30 days, zero point 0.6 4 to 7 days, and zero point 0.5 in the 3 days prior to admission. So overall, it's relatively rare. Now, if we look within the group, so this is within the 3,262 people who had used a psychedelic drug, 13.7% of those people had used in the 3 days prior to admission, 16% in the 4 to 7 days, and about 20% in the 8 to 30 days. So while it's rare, there is a subset, about 36% of those who had used a psychedelic drug did so within 30 days of admission. So just to give you some characteristics, so there's our sample size. I did report it, thankfully, and I was way off with my guess because it's early in the morning. So our total sample was 94,448 people at first admission who had had admission for at least 72 hours. So here we can see some of the demographics of that sample. 25% were 18 to 24. The majority, 40% or the largest proportion were 25 to 44. Almost 50-50 in terms of male versus female, slightly about 3% more males. Mood disorders are the most common primary diagnosis at 44%, followed by non-affective psychotic disorders at 23%, and 17% having a primary substance use disorder. So then if we look into people who had used psychedelic drugs, now this is the proportion of people within each demographic group who used psychedelics. So for those 18 to 24, 6.8% had used a psychedelic drug in the 1 year prior to admission, 3.6% in those 25 to 44. Males were had about twice the rate as females, and those with substance use disorders had the highest rate at 7.6%, followed by non-affective psychotic disorders at 3.8%. Now, if we look with just the within group analysis of those who had used psychedelic drugs, we can see that about 49% of those who had used a psychedelic drug were 18 to 24, and 43% were 25 to 44. So it was more rare in the older age group, but it wasn't completely uncommon. So we see here that about twice as many folks who use psychedelic drugs were male than female. And in terms of diagnoses, about 25% of those who had used psychedelic drugs had a non-affective psychotic disorder, 28% had a mood disorder, and 37% had substance-related disorders. So now I wanted to sort of highlight, okay, well, what were the percentage of inpatients who had used psychedelics and other substances in the 1 year prior to admission? So we see here in the total sample, 83% had used had 5 or more drinks in a single sitting in the prior 14 days. On this assessment, that's the indicator for alcohol. Alcohol is not when was the last time you had a drink, but it's rated in the prior 14 days, what was the most amount of drinks you had in a single sitting. And so five or more is typically indicative of a binge drinking episode. Within this sample, it's highly associated with the presence of an alcohol use disorder. So 83% had reported having five or more drinks in a single sitting. 36% had reported cannabis use. Um, 11% had reported using cocaine or crack. About 7% had used stimulants um, overall. So when we see none of the above at the bottom there, 58%, my apologies for the awkwardness in reporting. That's only representative of they had not used cannabis, inhalants, stimulants, cocaine, or opioids. It does not include the alcohol item there. Of course, these can add up to more than 100% because people can use more than one substance as well. So then when we look within the different substance categories, what percentage had used psychedelic drugs, we see that 28% of those who had used inhalants also used a psychedelic drug. But again, this is a relatively rare group in the sample, 308 out of 90, 94,000 people. About 7.6% of cannabis users had used psychedelic drugs. About 1.2% of those who had used alcohol used psychedelics. Um, 18% of those who had used stimulants, 15% of those who had used cocaine or crack, and 12% of those who had used opioids. Flipping it a little bit and saying, okay, well, of those people who use psychedelic drugs, which other substances were they using most commonly? We can see that it's clearly cannabis. 87% of those who use psychedelics also had used cannabis, followed by cocaine or crack at 57%, 31% who had used opiates, and 30% who used alcohol. So what's interesting about the alcohol and cannabis numbers, of course, is because they're so common in the total sample, the rate of psychedelic drug use among those groups looks relatively rare. But if you look at the N, it's actually a fairly large number of people. 4.3% did not use any other substances. So in other words, about 96% of those who use psychedelics had concurrent substance use in another category as well. What the pie chart here shows us is the number of other substances that people had used among those who had used a psychedelic drug. So 4.3% again had not used any other substances. About 24% had used at least one other substance. 22% had used two other substances in addition to psychedelics. 22% had used three or more other substances, 17% four or more, 9% five or more, and about 2% had used six or more other substances here. To break it down a little bit further, we also had a look and to say, well, what other, if they had used another substance, how many other substances in addition to that one substance were they using? So my apologies again. This graph can be a little bit confusing at first. We'll walk through it by looking at the cannabis results. What it's showing is this is everyone who had used a psychedelic drug prior to admission. For cannabis, the circled area means that they had used one other substance, meaning that about 20% of those who had used psychedelic drugs also used cannabis. And that was the only drug combination that they had reported or that had been assessed prior to admission. So they hadn't used any other drugs. And by far, that was the most common sort of dual combination when we look at people who had only used two substances, psychedelics and cannabis. We can see very clearly that that blue area, that darker blue area, is more rare across the other substance groups. So what that means, for instance, for cocaine, meaning that if a person had used psychedelics and cocaine, it's likely that they had also used a few other drugs. So my scaling here is a little off. So the two is actually means three drugs because it means psychedelics, cocaine, plus one other drug. So the two is actually three. The three is actually four. So, again, my apologies for the scaling issue there. But the main point here is telling us that folks who use other substances in addition to psychedelics are using multiple substances. And that's particularly the case for inhalants, where we noticed that a fairly large proportion of those who used inhalants used five or more substances as well. So again, this is a highly sort of acute group of folks who have much more complex needs in order to even get admitted to inpatient psychiatry. So it's not necessarily representative of polysubstance use that we might see in the general population. So the big question we also had was, what is the trends in substance use, and do the trends we see for hallucinogen or psychedelic drug use match what we would see for other substances? So this is looking at a 10-year period in these data. We can see that hallucinogen use is the bottom line. It actually is the most rare substance over time, so less than 5%. Now, if I were to zoom in on the scale, we'd actually see an increase in that percentage. It equates to about a 0.4% average increase over time. So while it's, relatively rare in this population, there is an uptick happening. The most significant increase that we see over time, of course, is related to cannabis. And what's interesting here is that in 2018, that's when cannabis was legalized for non-medical purposes in Canada. And so you can actually see leading up to 2018, there was already a significant increase happening. And that increase tended to continue post 2018. In some other research I'm doing, I'm looking at that more granularly, and actually post legalization, it does level out a little bit. What's interesting here is the binge drinking indicator around alcohol use. That's actually decreasing, but we see an increase in cocaine and crack, as well as an increase in stimulant use prior to admission as well. Now, if I were to look at this graph and redo this graph in terms of instead of looking at 1 year prior to admission and looking more specifically at 30 days prior to admission, it would look a little differently, particularly in terms of substances other than cannabis and hallucinogens. It actually levels out somewhat. So we got to keep in mind that not all of the substance use may be proximal to the person's admission to inpatient psychiatry. And so overall, what we see here is that psychedelic use among psychiatric patients is increasing, and it is occurring among younger and adults for sure. Most individuals who use psychedelics in this sample also used other substances, often in combination. So it's really difficult with this study to really determine whether or not psychedelics had any bearing on the person's acute status that led to that admission. And in most cases, it's likely not the case for the large majority. However, again, there is that very small group of those who had used psychedelics who did use in the 30 days prior to their admission. And so for a very small subset, it may represent certain complications that could be occurring. Um, a graph I didn't include here, but one that would be of interest would be also the association with psychotic symptoms. What we see when we looked at the positive symptom scale and the odds of somebody having used the hallucinogen prior to admission, the odds significantly increased in a linear fashion as more and more psychotic symptoms were present. So for a small subset of people in this sample, hallucinogens may be associated with their experience of psychosis for sure. We know that from the literature, of course, there is increased risk of psychotic experiences and psychotic conditions following psychedelic use for people who have family histories of psychosis. There's suspected that, of course, psychedelic drugs may act as a bit of a catalyst for those who may be predisposed to conditions like schizophrenia. So some future directions of this work is, of course, we need to identify some of the classifications of substances, and how those are associated with other clinical and social factors to determine, is it just a happenstance that they use these drugs, or is there actually a unique subset of this population that's experiencing certain clinical or social factors that are different from other populations in inpatient psychiatry? We need to talk to people who have used these drugs to tease out the reasons why they have used the drug, particularly people with, living with mental health concerns, to determine to what degree is it just experimentation, is it self-medication, are they using the drugs as an attempt to like counter either other effects of other substances or their mental health symptoms that they may be experiencing. We also need to look at, of course, pharmacological interactions and the impact of psychedelic drug use on the person's clinical status and outcomes over time, particularly if they continue to use psychedelic drugs after their admission to inpatient psychiatry. From a public health perspective, there's also some lessons that we need to consider. And I know in the US, there are some states that have been down this road too, in terms of Colorado and Oregon and California as well. But in Canada, what had happened prior to the legalization of cannabis for non-medical purposes was, as I mentioned, there was already an increase happening in use. So this graph actually shows us pre-legalization trends in cannabis use prior to admission to inpatient psychiatry. And there's a significant increase across all age groups. We know also that prior to it actually being legal in Canada, there was a lot of storefronts that opened up, and there was a lot of media talking about the potential medical benefits that are now being walked back a little bit, of course, as more research has occurred. And the concern here in relation to psychedelics is that the same trend is happening, certainly here in Canada. There's a lot of public discourse in the Canadian media about, psychedelic drugs. Are they safe? Should we use them? How could they help mental health? And we see a lot of storefronts opening up that are illegal dispensaries that, it's like the whack-a-mole where, they're shut down and then another one opens up two doors down again. So it's happening. And that happened with cannabis 10 years prior to cannabis actually being legalized. And we're seeing the same thing here with psychedelics. So while there are a lot of potential benefits, we need to be mindful of the education needed and the care taken on a public health standpoint to make sure that those benefits can truly be realized without inducing further harms. So thank you very much for the opportunity to speak with you, and I look forward to any questions you may have.